Two bone mets, their response was equal whether they had very extensive disease or small volume disease. But you do require a bone scan. Visceral mets are to be excluded. Non-visceral would be lymph nodes, which are smaller than 3 cm. They can have recurrence in the prostate bed or bladder. You can still treat them. You can monitor at baseline and prior to every dose. So before they come into the clinic, they pass by the laboratory downstairs, take a CBC. By the time they come up, we call them, they come inside, we can have the CBC already done. ANCs should be at least 1.5, platelet counts over 100 at baseline the first time, hemoglobin over 10. After subsequent treatments, the second, third, fourth, fifth, and sixth dose, ANC should at least be 1, platelet should be greater than 50. If they don't recover within the following 4 to 8 weeks after the last administration, you shouldn't treat, but what we do is we transfuse them. If they feel better, we treat them again. The standard dose is 1.35 micro. It's a microcurie per kilo IV, 4-week intervals. And again, the adverse reactions, which you have to tell the patients, may anticipate nausea, their GI symptoms, nausea, diarrhea, vomiting. Some few patients have peripheral edema. Thrombocytopenia is the more common one, in about 10–12% can have. It could be much higher if they have more extensive disease. Well tolerated, irrespective of chemotherapy, docetaxel use. Okay? For us, we do a baseline. We mostly now do technetium MVP. We used to do fluoride PET-CT in the trial setting early on. If they're still on trial nowadays, if they are randomizing with or without combinatorial therapy, we still do sodium fluoride because it's much easier to quantify than the MVP. But for clinical patients, it's MVP. So we do scan, treat, scan, treat, and then at the end of therapy, 4 to 6 weeks later, we scan. In a practical sense, do you really need all of this scanning? No. If you do the baseline bone scan, you treat 6 times, that's okay too. You may just want to do a scan if they develop a symptom at the middle of the cycle of 6 treatments or 6 months. So you can save on that. For us, we do that. It's just the way we do things. It's the way we assess for any progressions, both symptomatic or asymptomatic. It gives us an idea, at least, of how they are responding either on the visceral side of things, because when we do PET-CT with the fluoride, we can assess the viscera if they're progressing elsewhere. Or with the MVP, we can do SPECT-CT to assess the organs, and at the same time see if there are any sites of new activity or new sites of disease. Are they having pain in those sites? It allows us to correlate the imaging with the symptomatology if they're getting better or they're getting worse. This is what we look. I'm sorry it doesn't project, but I was supposed to be showing adenopathy in this patient, which developed on the second imaging. I mean, you look at the bone scan, it's no change, but over time the adenopathy developed in the para-aortic region. So these patients, then you ask the medical oncologist, do you want to co-administer abiraterone or switch? Because you have to make sure that these patients get treated for their visceral metastasis. So what we discuss with the patient is the goal is to improve survival and quality of life. The symptoms, you can have flare, and again, about 10% of patients, GI symptoms, blood counts could be lowered. Hand hygiene is important, especially after bowel movement, because it's fecal excretion. Avoid contact with body fluids or contaminated material. May want to use a condom for a first week after injection, but there's no restriction to returning to normal activity, contact with the public or the family. This was done to try to see if worst case scenario for contamination, because you can't even use the QT pie counter to detect it. It does not result in significant radiation exposure to the workers, we think. Again, because the range is very short, unlike the betas, etc. But, of course, you have to make sure the IV line works. If there's a sign of infiltration, one withdraws, puts a warm compress and elevates it, just like what we would do for IV extravasation of intravenous contrast or beta therapy. Why did we use fluoride? Because we have computer programs like the MIN program, which allows us to compute for the total volume of affected areas, volume where we could calculate the radiation delivery, and you can exclude bladder in this setting. Those patients who have very much higher volume of fluoride-avid disease, we call it total fluoride-avid disease, they do have a worse survival compared to patients who have small volume disease. You can separate perhaps the responders from the unlikely responders in an objective manner. We can tell them if their outcomes for their therapies may be good or bad, depending on the extent of the blastic metastasis. And then we could use this technique actually for breast cancers and the sarcomas which we have used it for. And this is what we published for using fluoride PET-CT, use this segmentation method, fluoride volume levels of disease. And again, you can assess total disease burden and response with patients, so you can actually graph the volume. So you don't have to look at every single lesion, but you can have a volume estimate to see the reduction in the volume, which may be easier to see. Sometimes the numbers are easier to comprehend than the actual number of lesions, because you're dealing with a lot of lesions. You can see before and after, before and after. It's easy to say this one is, the baseline is here, this is very good response, this is very bad disease, this is an okay response, but maybe it might be worse, right? So, but if you look at the volume, it's much easier to see this is very much more extensive involvement, because it's very hard to try to count these lesions one by one. You can't base it only on one new lesion, two new lesions. It's easier if you base it on the volume of the lesions in our mind. And if you have a way to just draw one rapid volume and it calculates it for you, it's easy. It's easy if it's in this setting when it gets better. How bad is it? It's very difficult. So this is 110 patients treated with over 500 cycles. We looked at this. This is after it got approved. What are the factors which predict response? Will patients benefit most? When do we treat the patient? Of course, we want to treat early. When you wait until the other options are exhausted, it's usually not good. And you can run into bone marrow failure, as was alluded to before. So those patients who completed radium-223 6 times had reduced risk of death. The progression is less, skeletal related events is less, and the occurrence of marrow failure is actually less because you treat them. They completed the treatments because they don't have extensive disease. Patients who completed on progression versus patients switched to chemo, the patients who got radium actually lived significantly longer than those who were on chemo. Our overall survival is shorter because compared to Alsimca, our patients were much worse. They had intermediate to high tumor burden. Some of them we treated despite noting they had nodal or visceral metastasis, what we call off-label use. And there was still a benefit despite advanced disease. There was relief of bone pain. There was the alkaline phosphatase non-reduction or poor status. Their Vertiker was predictive of overall survival. There was flare in this series, 14%, and those still had symptom improvement if they had flare. Typical example before and after scan, first cycle. This is the PSA level. second cycle, third cycle, fourth cycle. So you can have some responses on the PSA if it's bone predominant disease, and you can see it on the scan that it improves over time. Again, there's a clear progression-free and overall survival. You reduce the risk of death in a large number of these patients. It is just a few months or up to a year, but in these patients, these patients who have external beam radiation because the marrow has been killed off, or when you radiate, the marrow is wiped out in certain areas. The risk of marrow failure is slightly higher, but no association of marrow failure development was seen with chemotherapy, only with external beam radiation. On multivariate analysis, those who got the full 6 doses and abiraterone combination, which is you continued them on androgen deprivation therapy, was associated with overall survival. That's why we're continuing this trial where we randomize patients on abiraterone. They either get radium or saline. So total treatment and external beam radiation, total means 6 treatments were associated with marrow failure. These are the patients whom we wanted to see if the bone scan can predict marrow failure. It can. If they have a very high volume, instead of the 10,000 over 12,000 volume or greater, it was a high risk of marrow failure in these patients. These are the types of patients where we've seen marrow failure. This one patient died with bone marrow failure. This one died without marrow failure, but these patients are still alive and well. The key is, if you treat early, when they have fewer lesions, the fewer the better. The survival benefit is the greatest, particularly when associated with continued androgen deprivation therapy, which is abiraterone. They have more moderate disease. They still have a good benefit. They don't get marrow failure, but we have very extensive disease. They can develop marrow failure, and the survival benefit is not as long in these patients. Okay, we've finished the trial for osteosarcoma. Here's the bottom line: it did not provide an overall survival benefit for these patients. Again, because when we look at the sodium fluoride, TLV, as well as the fluorodeoxyglucose, because we were looking at glucose activity, we realized that there's a difference between the deposition of the fluoride and the FDG. So there's a significant volume of FDG-avid disease which is not fluoride-avid. So those are the sites which do not respond well because there's theoretically no radium deposition. So you can see FDG, fluoride more extensive. There are other lesions which are seen. Then you have the spine mets which are not avid, but then they can progress. You can see here. So it's variable. In lung metastasis, you will see, we've seen in patients who have been biopsied that only the more calcified component will have a reduction in FDG activity over time. So it's a variable response. The imaging with fluoride tells you the deposition of the treatment. The FDG may tell you that there are some areas which are not reached by the fluoride-avid component, so that's why you can have failure in these patients. Then they can progress over time. It can go to brain metastasis. It can cross the blood-brain barrier, but again, you can see it doesn't cure these patients. That's what I'm trying to say. It can kill a certain volume of cells, but eventually, because you do not reach the full spectrum. So what people like us are thinking about are not only combinations of therapies, but also combinations of the betas and the alphas, or something which is like the PSMA, which has a more visceral component. The trial for breast cancer is still ongoing. There is a response which we can see both with FDG and with fluoride, and we expect the trial to be a positive trial and hope we can get approval for breast cancers, but it's not yet approved. Alpha therapy with actinium-225, we'll have Fred talk about this. They presented this at the SNM. At the SNM, they presented 40 patients. High activity against metastatic castrate-resistant prostate cancer. Again, single center, retrospective analysis. Xerostomia was a relevant side effect. They say it's low hematologic toxicity. They said in their abstract that for solitary or few mets, lutetium PSMA may be better, but it has less salivary gland toxicity, although it has less anti-tumor activity. You have to understand that this was done over 100 years ago, the radium therapy. She already called it Curie therapy, Marie Curie in France and then in other countries. So with that, I'd like to thank you very much for your attention. Any questions on radium? Yes, sir.